Good morning, everyone, and welcome to Tyro Multidisciplinary Seminars. We are joined this morning by Dr. Debbie Chen, who's a clinical instructor in the Division of Metabolism, Endocrinology, and Diabetes at the University of Michigan. Her research interests are in the area of addressing disparities in thyroid cancer care with a focus on managing patients in a vulnerable population. She's the recipient of numerous grants, including the University of Michigan Research Training Grant, the Rogel Cancer Center Discovery Award, among several others. I have the pleasure of introducing our discussant this morning, Dr. Zubair Baloch, who has been a part of the numerous Tyro programs and is a member of the Tyro Advisory Board. He is currently professor of pathology and laboratory medicine at the University of Pennsylvania Medical Center. He has had an extremely productive academic career with over 200 peer-reviewed publications, as well as co-authoring 3 books. Of note is that he served on the NCI committee that led to the development of the Bethesda Thyroid FNA classification scheme, and relevant to this morning's discussion, he also served on the panel that led to the renaming of non-invasive follicular tumor with papillary-like nuclear features, which obviously makes him uniquely qualified to discuss this morning's paper. And so with that, I'm going to turn over the program to Dr. Chen. And as always, I welcome all of you to send in your questions and comments, and I will do my best to get to those before the end of the hour.
So thank you so much for inviting me to be here this morning to present on our manuscript that was entitled Variation in the Diagnosis of Non-Invasive Follicular Thyroid Neoplasm with Papillary-like Nuclear Features. And this was published in JCM last year. So I have no disclosures. So to give some context to this topic, I want to first discuss what is NIFTP and how did it originate. So over the last few decades, the incidence of thyroid cancer in the US has increased significantly, as you can see in the figure on this page. And with the light green boxes here, you can see that the incidence had increased significantly over time, whereas the mortality from thyroid cancer, which is in the inverted triangles at the bottom, was relatively stable. And so many studies have suggested that this was related to the overdiagnosis of thyroid cancer in the setting of readily accessible ultrasonography. So in 2012, the National Cancer Institute held a conference to address the problem of overdiagnosis and overtreatment in cancer, and subsequently released a statement emphasizing the need to revise terminology and replacing the word cancer for more indolent tumors where appropriate. So in their paper, they had written, "We believe that several changes should be made to the approach to cancer screening and care, such as use of new terminology for indolent and precancerous disorders." So soon thereafter, an international group of experts, including 24 thyroid pathologists, 2 endocrinologists, 1 surgeon, and 1 psychiatrist, met to re-examine the diagnosis of non-invasive encapsulated follicular variant of papillary thyroid cancer. And one of the significant outcomes of this meeting was a recommendation to reclassify this tumor as non-invasive follicular thyroid neoplasms with papillary-like nuclear features, or NIFTP. And based on the very low risk of adverse outcomes, including an estimated 15-year recurrence rate of less than 1%. So this diagram is intended to provide some context of how non-invasive encapsulated follicular variant papillary thyroid cancer, or what is now called NIFTP, fits into the overall scheme of differentiated thyroid cancer. And here is where NIFTP is. The orange shows the categories in which it falls into, such that it's non-invasive, encapsulated, and follicular variant of papillary thyroid cancer, as the name suggests. So going back to the international group meeting, so to assist with the diagnosis of NIFTP in routine pathology practice, the authors developed and validated a simplified diagnostic criteria for NIFTP that you can see here on the left in the box. And then they estimated that this reclassification would affect more than 45,000 patients worldwide each year, and thereby significantly reducing the psychological burden, medical overtreatment and expense, and other clinical consequences associated with the cancer diagnosis. So soon thereafter, So soon thereafter, the topic received much press, including in the New York Times. And I've included two quotes from the New York Times article here to illustrate that this was thought to be a game changer by the lay press, and to highlight that there was also confusion about how the diagnosis of NIFP would impact patients. As a result, they have officially downgraded the condition, and thousands of patients will be spared removal of their thyroid, treatment with radioactive iodine, and regular checkups for the rest of their lives, all to protect against a tumor that was never a threat. And the change is expected to affect about 10,000 of the nearly 65,000 thyroid cancer patients a year in the United States. Then in 2021, Ren et al. Published a meta-analysis that assessed the worldwide impact of this reclassification and use of the term NIFP, and it included 50 retrospective studies that included more than 100,000 patients with papillary thyroid cancers and close to 4,000 patients with NIFP from 92 institutions worldwide. The authors found that the overall incidence of NIFP was 6% of all papillary thyroid cancers worldwide. They also found that the incidence of NIFP was largely similar in North America and in Europe, and that the incidence of NIFP was about 10% in the United States. Based on their analysis, the authors estimated that this reclassification would affect upwards of 30,000 patients worldwide. So far, I've discussed what NIFP is and the anticipated impact that this nomenclature change would have at the population level. But how exactly does the use of the diagnosis of NIFP affect patients at the individual level? So this figure illustrates how the reclassification of NIFP as a benign lesion has led some to recommend a de-escalated and less aggressive management strategy than that recommended for low-risk differentiated thyroid cancer. And so focusing on the right half of this figure is the management strategy that would traditionally be recommended for patients diagnosed with encapsulated follicular variant of papillary thyroid cancer. So for those patients who underwent a thyroid lobectomy, a subset would then undergo conservative annual surveillance, whereas some would undergo completion thyroidectomy that was sometimes followed by radioactive iodine ablation. And all patients who underwent completion thyroidectomy would need lifelong thyroid hormone replacement therapy as well as annual surveillance. In comparison, if you focus your attention on the left half of the figure, patients diagnosed with NIFP after lobectomy would not require completion thyroidectomy or radioactive iodine. And to the best of my knowledge, there's currently no guidelines on the optimal surveillance for patients diagnosed with NIFP. So their study quantified the amount of cost savings and the improved quality of life resulting from a de-escalated management of NIFP, with the cost of care in their model based on societal costs and estimated with Medicare reimbursement information rates, such that over the course of 5 years, a de-escalated management was projected to save about $3,800 and improve quality of life by 0.03 quality adjusted years per patient. So far, it seems pretty positive with the name change to NIFP. Patients don't have to worry about having, quote, a cancer diagnosis. They have less extensive surgery potentially. They're less likely to require lifelong thyroid hormone replacement, and they undergo less intensive surveillance. And there's a huge societal cost saving. So why exactly should we be concerned or potentially be concerned about this NIFP nomenclature change? Like, what is the downside? So soon after the name change to NIFP was recommended in 2016, some studies were published that made us question whether or not NIFP really was a benign tumor. So in particular, there was 2 retrospective studies of patients diagnosed with NIFP that was conducted by Presents et al. And by Cho et al. That is highlighted in this red box here. So in the study by Cho et al., which is here at the bottom, which followed 200 patients diagnosed with NIFP over a median of 3 years, the authors reported nodal or distant metastasis in 3% of the cohort. Then in a study by Presents et al., which followed 102 patients diagnosed with NIFP over an average of 5.7 years, the authors reported nodal and distant metastasis in 6% of the cohort. So in response, and to minimize the risk of misdiagnosis, Nikiforov et al. Subsequently proposed stricter diagnostic criteria for NIFP in a follow-up publications 2 years after their initial studies. And I've highlighted the main changes in the red box, which includes a primary criteria that you can see up here of no well-formed papillae, which was compared to the prior comment of less than 1% papillae, as well as the inclusion of secondary criteria of absence of BRAF V600E mutation or other high-risk mutations. So the North American Association of Cancer of Central Cancer Registries, or NAACCR, develops and promotes uniform data standards for cancer registries, such as uniform cancer coding. And so it's used by all central cancer registries in the US and in Canada, including surveillance, epidemiology, and end results, or SEER. So effective January 1st, 2017, in part due to study findings by Nikiforov et al., the coding scheme was modified such that non-invasive encapsulated follicular variant of papillary thyroid cancer was reclassified as NIFTP, or non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Then, since NIFTP is no longer considered a cancer, as of January 1st, 2021, it is no longer a reportable diagnosis to SEER. And so this means that the outcomes of patients diagnosed with NIFTP is no longer captured by a registry that some consider to be a premier source of cancer statistics in the United States. So given that most existing data on NIFTP comes from retrospective studies, mostly at single institutions, and little is known about the broader impact of how this diagnosis has been used in the United States, the goal of our study was to, one, identify trends in the incidence of thyroid cancer by subtypes and NIFTP, and two, to determine how the diagnosis of NIFTP has been utilized across different US regions and patient populations. And so we use SEER as our database for the study, since it collects cancer data from population-based cancer registries covering approximately 48% of the US population. And it also has a diverse representation that includes both urban and rural regions. And so first, we identified individuals that was diagnosed with papillary or follicular thyroid cancer from 2010 to 2019, and individuals who were diagnosed with NIFTP between 2017 and 2019 based on the ICD histological coding. And 2019 was the end year because it's the latest year for which SEER data was available at the time. And so first, then we looked at data from 2010 to 2019 and examined trends in thyroid cancer incidence rates based on the histological subtype. Incidence rate was calculated as the number of cases for each subtype divided by the total number of thyroid cancer cases, or NIFTP, reported to the SEER22 registry. Then we restricted cases to those from 2018 and 2019 to determine how the diagnosis of NIFTP has been utilized across different US regions and different patient populations. And so we felt that 2018 and 2019 was much more likely to be representative of contemporary NIFTP usage in the US compared to 2017 when the coding was first implemented. And so in these cases, the NIFTP incidence rate per registry site was calculated as the number of NIFTP cases divided by the total number of cases at each registry site. And so between 2010 and 2019, we identified a total of 218,929 cases, which included majority of papillary thyroid cancers. And then there was 1,473 NIFTP cases in our cohort. So the patient's median age was 50 years, ranging from 0 to 100 plus, and then predominantly female, white, and non-Hispanic. So this figure here illustrates a trend in the incidence rates of thyroid cancer by subtype and NIFTP. And the line graph here on the right is actually a zoomed in version of the line graph here on the left, and this gray area that's here at the bottom. This is just very zoomed in. And so on this figure on the left, you can see that between 2010 and 2019, there was a statistically significant increase in the incidence of general papillary thyroid cancers. And then here on the right, where I've placed the arrows, you can see that there was a statistically significant increase in the incidence of columnar or tall cell variant of papillary thyroid cancer, of minimally invasive follicular thyroid cancer, and of encapsulated papillary thyroid cancer invasive encapsulated follicular variant of papillary thyroid cancer, as well as a decrease that you can see here in the arrows here in the incidence of follicular thyroid cancer and diffuse sclerosing variant of papillary thyroid cancer. Then focusing on 2015, where I put the dotted gray lines vertically to 2019, here on the figure on the left in green, you can see that there was a statistically significant decline in the incidence of follicular variant of papillary thyroid cancer from 27% to 15%. And then here on the right in blue, you can see that there was a statistically significant increase in the incidence of encapsulated papillary thyroid cancer or invasive encapsulated follicular variant of papillary thyroid cancer from 0.7% to 2.8%. And then in red is for NIFTP, you can see that between 2017 and 2019, the incidence rose from 1.5% to 2.6%, although this wasn't statistically significant. And so as such, we determined that between 2015 to 2019, the incidence of follicular variant of papillary thyroid cancer sharply declined, with an observed increase in NIFTP and encapsulated papillary thyroid cancer or invasive encapsulated follicular variant papillary thyroid cancer, together accounting for about 34% of that decline. And then looking at the absolute number of cases per year, we see that there was only 509 cases of NIFTP in 2018 and 624 cases of NIFTP in 2019. And so this accounted for 2.2% and 2.6% of all cases respectively, which is significantly less than the initial estimates of how many patients would be diagnosed with NIFTP in the United States. And so part of this discrepancy between our NIFTP incidence rates and prior studies we thought was potentially due to prior studies being based on primarily single institutional data from large academic centers. Because when compared to other population-based studies using other registries in SEER, the numbers are much more consistent. And so in addition to trends in incidence rates, we also looked at variations in how the diagnosis of NIFTP has been used. And so this figure is a spatial plot of the US that illustrates regional variation in the incidence of NIFTP in 2018 and 2019 combined. And so here the percent of NIFTP is out of all cases of papillary thyroid cancer, follicular thyroid cancer, and NIFTP per registry site. And it's depicted by the size of the circle, with a larger circle representing regions with higher percentage of NIFTP. And so if you focus your attention here on the right with the numbers, you can see that between 2018 and 2019 combined, there's significant heterogeneity in the regional use of NIFTP diagnosis, with incidence rates ranging from 0% in Alaska to 6.2% in Seattle, with a median of about 2.8%. So we also observed significant differences based on patient demographics. So as highlighted in the red box and with the arrows, a diagnosis of NIFTP was significantly associated with older age, with Black race, and with non-Hispanic ethnicity compared to diagnoses of papillary and follicular thyroid cancer. So in summary, our study found that NIFTP comprises only a small fraction of the total thyroid cancer cases in the United States, which is significantly less than that initially anticipated based on case reports in the late press. And moreover, market variation exists in the use of the NIFTP diagnosis, both regionally and across patient demographic groups, with potential for downstream disparities in thyroid cancer outcomes. And so the reasons for the observed variation includes the recognized and well-documented subjectivity in histological interpretation, in addition to different practice patterns and preferences among pathologists regarding the use of alternative diagnoses of follicular adenoma and encapsulated papillary thyroid cancer. Furthermore, similar to other aspects of thyroid cancer care, this variation may reflect differences in patients' access to thyroid care based on non-clinical factors. And so ultimately, NIFTP appears to be a tumor with uncertain malignant potential, and for which there is no longer long-term outcome data available. And so the recent coding change that resulted in NIFTP no longer being a reportable diagnosis as of 2021, and the lack of consensus among clinicians on how to appropriately monitor NIFTP will disproportionately impact older patients, Black patients, and patients who reside in regions with higher rates of NIFTP diagnoses. Thank you so much, and I'll stop sharing my screen.
Thank you, Debbie. That was really good. And I have to say this, you know, I was very happy when I read that paper, because when I'm in the meetings, most of our Asian colleagues from Asia and other countries always say, like, you know, that Americans, especially North Americans, really call NIFTP or follicular variant more than those things should be called adenoma. So when you boil down everything, it really, I'm glad to know that this is not a diagnosis which is made too much. You know, I think it's a pretty good balancing act at this point. So, you know, taking what Debbie talked about, and you will see that some of the slides may appear very similar, and I'm going to quickly go through them, but I just want to give you a perspective. I think this is a good time to look back from a pathologist point of view and see, how this diagnosis has come about, which was really good and nicely explained by Debbie, and how it goes. So I really do not have any enormous financial relationships, or basically none at this point. So I wish I did at my age, but that's the way it is. So what I think of when you're thinking at the current status of thyroid neoplasms, and let's think about the malignant neoplasms, also the low risk neoplasms, where this NIFTP diagnosis kind of relies. It means low risk of recurrence. It's a mishmash at this point, but what really points out the most important tumors that we see in our current practice, and how this practice paradigm has changed for diagnosis, which is preoperative by fine needle aspirations. And I have to mention this because I'm also a cytopathologist, and the molecular profiling. And it is not just the diagnosis, but it has allowed us to really how we understand this disease process, and understanding from a pathologist point of view. And Dr. Lavolsi and Dr. Brandywine is on this also as an audience. How the pathology diagnosis really is a really integral part, or even at the center of how these patients are managed. So I think it really, the understanding really starts, at the grassroots. So now when you look at the 5th edition, or the 4th edition, which is current, and the 5th edition of thyroid classifications coming through, you can see that the NIFTP kind of lies in the other encapsulated follicular pattern thyroid tumors. And I think this was the best and remarkable jump in these diagnoses, and how we started to understand, and we just did not put these tumors into a benign or malignant boxes. So we started to understand, because we know biology does not work like this. This is all on a spectrum. And this is going to be the 5th edition WHO classification, which is in the press. And as you can see, again, there is a low risk neoplasms, and the NIFTP is actually on the top of this. So, which is really, I think this is where it sits. Historically, NIFTP cases were called as follicular variant of papillary carcinoma encapsulated. And there were different versions of follicular variant of papillary carcinoma, and this is kind of depicted in this cartoon here. Now, when you boil down after 2016, what we have ended up, which is based upon the nuclear cytology of papillary thyroid carcinoma, which can also be seen in cytology specimens, and the lack of the nuclear features of papillary carcinoma, and based upon invasive growth patterns. So nuclear features of papillary carcinoma, but even if you take that out of the equation, I think what really matters in pathology is invasion. Encapsulated tumor, follicular pattern, follicular adenoma, and follicular carcinoma based of presence or absence of invasion, and no nuclear features of papillary carcinoma. And if you add this, then you end up with NIFTP and a follicular variant, which is an invasive tumor. So this is how the illustrative way of thinking about these tumors. Now, what are the questions? I think that it always comes in when you apply a diagnosis in the clinical practice, and what does it matter? And I think you just go by what is in the literature. But I also want to mention that the literature is very heterogeneous. Most of the literature is coming from larger academic centers, which kind of see a more skewed populations of the patient, which is coming through, which are going through also massive other screening protocols. And as you know, when you really screen these patients, and if you screen the neck, you up to 60% of these patients is going to have one or more thyroid nodules. So I think you had to kind of look at this data also with a grain of salt. And when you do the meta-analysis, it really boils down to what Debbie was talking about. So I think it's really one of the questions was that if you have a second tumor in the thyroid gland, which is a carcinoma, does it change the diagnosis of NIFTP? No, it does not. You can still have NIFTP with outright carcinomas, which can be invasive. They can be of different sizes. NIFTPs can be multiple, and they are not included in the staging of thyroid tumors. And then the other thing was the size. I mean, the larger size tumor, up to this date, I am really careful when I'm calling something which is large size tumor that looks like NIFTP, I have to make due diligence to make sure that I am not missing invasion, I'm not missing any form of papillary formation, to make sure that it is. And this really was brought up by multiple studies, including one of the studies from Huck also, that we said that tumor measuring 1.0 centimeter or less have not been included in the NIFTP paradigm in the 2016 papers and even in the revised, but these now small tumors can be called NIFTP. One word of caution, when you come up to 0.3 or 0.2 centimeters, and we are also talking about microscopic measurement on the microscope, you have to be careful on calling these tumors NIFTP because you really don't know if there's papillary formations or not. And as we know, some of these small tumors can lead to metastasis. NIFTPs can also be of large size, and they can also be oncocytic because these paradigms were really not included in the 2016. And this is one of our the studies that we published in endocrine pathology. And as you can see, these small size tumors had, at a mean follow-up of 12.1 years, had no tumor recurrence. So smaller tumors can also be called as NIFTP, and I usually use it for 0.3 to 1 centimeters. Now, what were the pros, and this was brought up by Debbie, was this big conundrum about papillae. Now, and I will tell you, there is still inter-observer variability. What is a true papillae? To me, a true papillary formation, which you see in the classic variant of papillary thyroid carcinoma, and I will illustrate a case for you that was graciously given to me by Dr. Lavolsi to share with you what you really, just to highlight this factor. A true papillae, which you see in classic variant of papillary thyroid carcinoma, has a beautiful fibrovascular core and lined by cells, as compared to sometimes these little projections that you see in larger follicles. I know there's a lot of clinicians on these calls, and they may say, what is he talking about? But I think I want to tell you some of these really little nuances really help a pathologist or make even things complicated for us when we're looking at this diagnosis, i.e. what leads to heterogeneity in these diagnoses. And as we know, some of these tumors have papillary formations, and this slide, I'm not going to really go through it too much. But what I want to point out that some of these studies may have been lacking when there was entire tumor was sampled and examined, and if there was not other microcarcinomas in the gland, even if some of the studies did point it out that there were none. But based upon these studies, if you can see that these criteria were changed. So now this is actually the case that came to Dr. Lavolsi for consultation, and she shared it with me. It's as you can see on this side, this is, let me just use this and see if this works. So this is an encapsulated nodule. As you can see, it has a really good gap, which sometimes looks like a halo around that you can see in the thyroid, on the radiology. And there's a normal gland. And this was called as a NIFTP, but then there is a metastatic focus in the lymph node. Now, when you look at it naturally, this looks like a thyroid tumor here, which looks like papillary carcinomas. And this was TTF1 positive, which is one of the transcription factors, which is expressed in thyroid cells of follicular origin. Now, if you look back at that tumor in the thyroid, which was called NIFTP, and you go in and you do submit like sections, one of the 21 sections that was submitted, and Dr. Lavolsi really pointed that out, that there was a focus of papillary formation. And these are true papillae, because I want to just not labor it out too much, but just to show you that there is a beautiful fibrovascular core, which is lined by these nuclear features of papillary thyroid carcinoma cells. And there you can see a really well-developed core. So this is a true classic papillary growth pattern. So this tumor is actually not a NIFTP, it has that mixture of growth patterns. So as you can see, which led to metastasis, and some of these have BRAF. So this again was pointed out by Debbie for you, and the criteria has changed, and that was by the same group which put together these things. So in a clinical practice of pathology, everyday pathology, what matters? Because when you're making a NIFTP diagnosis, you need to exclude the invasion, you need to exclude the papillary formation. So naturally, the thing goes in my head. I have to submit the entire tumor, which we do. I have to examine the entire capsular interface with the tumor to make sure there is no invasion. And there is way of grossing these thyroid tumors. And sometimes you can end up with a lot of slides to really exclude invasion, plus exclude those papillary formations to make sure. So the diagnostic criteria, what it boils down to have to be very strict. Now, I think what we also have to think about is what happens, at this point, we're focusing on search path diagnosis. What happens when there is a preoperative FNA of these nodules, which most of these nodules do. And as we know that these tumors can have NRAS mutations with a medium to low allelic frequency. They can have other fusions which are of low risk, like PADA fusions or EZH1s. And this is actually one of these nodules, which was the case. And you can see it's absolutely gorgeous nodule here. There's a needle in it, and this was the cytology slide. So definitely it looks like a neoplastic process because it has a monotonous population of follicular cells, which are arranged in follicles. And I just want to point out, you do not need to be a pathologist to really see that these nuclei are elongated. They have really tiny nucleoli and beautiful intranuclear grooves and the powdery chromatin. So this is actually very suspicious for papillary carcinoma. It is lacking those intranuclear inclusions. And that's why this was diagnosed as suspicious for papillary cancer and was sent for molecular analysis. And the molecular analysis showed NRAS mutations. And as you can see here, this is definitely an encapsulated nodule, which is not invasive. There's a really nice, well-behaving tumor here, follicle formation, and really gorgeous nuclear features of papillary carcinoma, which was NIFTP. Now, I want to show you just another case for comparison. This is another case that we called as follicular neoplasm because it had really these gorgeous monotonous nuclei forming microfollicles. And as you can see, there's a little bit of a chromatin change, but not as intense as in the other case. This case came back when it was submitted for molecular as NRAS and TERT promoter mutations. Now, if you look at on the search path of this tumor, most of it is this follicular pattern tumor encapsulated and have nuclear features of papillary carcinoma. It was invasive, not angioinvasion, but definitely capsule. But you can see these areas of necrosis in it and poorly differentiated transformation to poorly differentiated carcinoma. So these preoperative FNAs can really beautifully separate those out. If you are doing molecular analysis, which, there are different tests, and I'm not going to endorse which tests you should do, really can figure out which is going to be of this low-risk neoplasm or point out toward this being a low-risk tumor on the molecular profile so the patient does not need this extensive surgery. So this was just to give you this comparison. And when you look at the rearrangements and the molecular profile of these tumors, you can see it is between NIFTP and follicular adenoma, kind of really similar. Most of them do have the RAS mutations. They can be HRAS, but most commonly NRAS mutation. They do have BRAF K061E. If a tumor pops up as BRAF V600E mutation, I will not call that this is going to be a NIFTP, even if I call it suspicious for papillary carcinoma. Now, I just want a word of caution. There can be a very small percentage of these tumors which can have TERT promoter mutations, but very low level and clonal, which can happen into low-risk neoplasm. You can also see PADA fusions and Paxate PPRI gamma as NTRK in some of these cases. So based upon this molecular profile and FNA cytology, you can suggest a diagnosis of NIFTP preoperatively, which is actually used as a note or a recommendation from the Bethesda classification scheme. So now I think we have to be a little bit careful now when you're looking at the literature and see what has changed and what is changed for good, what is still needs workings. So, we don't panic that, we're making these NIFTP diagnoses. And I have to actually tell myself and kind of relax myself sometimes and say, this tumor is encapsulated, not invasive, has nuclear features of papillary carcinoma, this is definitely a NIFTP. And most of the pathologists have been talking about it for greater than 10 to 20 years, saying that these tumors are low-risk tumors and the surgeries are very extensive. But we were kind of forced at this point to definitely call these carcinomas, and I'm actually glad with this diagnosis. And as some of these were pointed out, that if you look at the follow-up, it is limited. We also always knew that the follicular papillary carcinomas, which are encapsulated or even have capsular invasion, no angioinvasion, confined to the thyroid, you really need a long-term follow-up to see how these tumors are going to behave. So I think the story is going to unfold, but I am hopeful that it's going to unfold and really basically going to confirm what we see on cytology, surgical pathology, and in our even short-term follow-ups. So this is actually, when you look at it, it has also changed the world of cytology, how we diagnose these cases. And now the Bethesda system for reporting thyroid cytology report that we should put in our notes that if you call something AUS Bethesda 3, Bethesda 4, or 5, you do put in that this could be a NIFTP, because pathologists always worry about surgeons calling back or the clinicians calling back and say, you said suspicious for malignancy, but it was NIFTP. But that is the nature of the beast. So I think we all have to work in multidisciplinary fashion. This is actually pointing out, somehow we always were blamed that the Northeast always calls too many follicular variants. And so we just looked at our NIFTP experience, and this is from 2017 to 2022, which you can see we had only 121 cases of all our papillary cancer comers, and it include all papillary thyroid carcinomas, all the nodules. So it was actually less than, close to like 1% or less. If you look at the ultrasound findings and the FNA, most of these cases had FNAs, and I just want to point out that these cases are going to land into Bethesda 3, 4, or Bethesda 5. Most of them are actually in Bethesda 3 and 4 as compared to the prior studies, which were retrospective, saying that these are going to be more of the Bethesda 5. Majority of these patients did go under lobectomy because their molecular profile was either NRAS or TADA fusions. The average size was 2.5, but as you can see, there was one tumor which measured 8 centimeters, and that was 73 or 78 slides that I had to go through and look at these, and this was a NIFTP, and the patient so far is doing fine. You can have other tumors in these patients. You can also have multifocal NIFTPs, but they're not very common. In our cohort, is on the 121 cases, we only had 2 patients. And I know this is a very limited follow-up from 2017. So it's like, you're talking about between 5 years or 6 months to 5 years, but there's no evidence of recurrence and the patients are alive and doing well. So I think if we put our heads together as a multidisciplinary team, the pathologist, as a cytopathologist and surgical pathologist, really can point out, and if we really even take away the diagnosis of NIFTP from our mind, that this is going to be a low-risk neoplasm with a low risk of recurrence, and they can be really treated with minimal surgery that do not require that extensive surgery, unless something is happening in the opposite lobe, or there is already a lymph node met. So I think this was kind of a bird's eye view of looking at it. I think this story is unfolding, but I am really of the understanding that this is going to unfold for better, and it will really increase our understanding of how thyroid tumors behave and how we can manage them. So thank you so much. I'm going to stop sharing and then see if there are any answers.
So Debbie and Zubair, thank you so much for your presentations. And Debbie, thank you for all the work that went into putting that study together here. Let me just see first if Debbie has any questions or comments for Zubair.
I thought that was so phenomenal. I thank you so much for kind of making it very obvious, like the challenge with the papillae diagnosis. And I think it really puts into perspective why, despite the variability in some of the case reports, that if you're able to really truly make a diagnosis in NIFTP, that's likely where, the initial numbers of the low recurrence rates came from. I think kind of what you pointed out with the studies or the case reports having higher risk of nodal or distant metastasis, it may have been more, at this point with the revised criteria, it really probably would not have met that NIFTP criteria anymore. So thank you for that.
Yeah, I think I think if you look at some of the studies, when you introduce the term retrospective, these cases have already been diagnosed. And then you're looking at those cases from a very different point of view than looking at the cases in real time. I always think there is something misses when you go look at cases retrospectively, and we all have been, guilty of that. We go back, look at our cases, really define them, and that's how the NIFTP study came about, because it was a retrospective view. But I think this diagnosis, personally, it's not like I'm afraid of it, but when I did this diagnosis, I have an extra responsibility on my shoulders to make sure that when I am doing that, making that diagnosis, I'm following all the diagnostic criteria to make this diagnosis. If I see papillae, if I see any form of invasion, I try to make sure that I go through the block to make sure this is, invasion. It does put a little bit more stress on the lab to do this, but when we're telling a patient that you have a lobectomy, that's enough. You're not going to do anything else, even specifically in a sizable tumor. I think it's sticking to the diagnostic criteria, and what we'll see prospectively coming out, I think it will make our understanding or cementify most of these concepts.
Terrific. Let me ask you, Zubair, do you have any comparative studies with respect to the uniformity of diagnosis of NIFTP amongst senior experienced pathologists? How much concordance is there? Yeah.
I mean, I think I really am not aware of studies where somebody had, it was more before NIFTP where the slides were passed among different experts. And this is where the whole observer variability came about. Even among experts, you went from a carcinoma diagnosis to a hyperplastic or adenomatous nodule, some of these tumors. So I do know there's a study from somebody has looked at the diagnostic rates between Asia versus Europe or America. So there's definitely a big drop in the Asian population. But I will tell you from an institutional point of view, we are pretty, we show each other cases. I think, and that is very important in a pathology department to really understand. Plus, when you have an FNA stuff available on these cases, the molecular profile is available. That also gives you more information that what you should be looking for. And the radiology to say radiology was invasive growth pattern, and you're getting a pretty sizable nodule with very well behaved. I have to make sure that I am examining the sections correctly, and most sections are submitted to see if there's nothing else aggressive going on. So I think it's very, I think, to be honest, Mark, I think when you're looking at this variability, we actually, as a clinicians and as a pathologist, includes pathologists and radiologists, the things that we do in our institution, and we add that experience to the journal pool, we do add a lot of variabilities, right? This is the way I do things. This is the way you do things. What is wrong and what is right is everything is in the middle. So, so for me, it's what is coming out of discussions is invasion is becoming more and more important than really looking at the nuclear cytology. So for me, and once we decide what invasion counts, whether this is just a tumor which is invading in its capsule or it's also invading into the blood vessels, once we sort that out, which I think still needs to be sorted out, I think we'll be at a good place to really decrease this variability and this big gap that we'll see between institutions. So that's where the papillae things comes. Some people, I have seen cases in which those are really not true papillae. They are just something like outpouchings. You can see them in goiter also within the follicles. And somebody said, no, that's papillary formations. No, you have to have a strict criteria to say something which has true papillary formations, because otherwise you will not be calling anything NIFTP. So I think once that is all sorted out, and I think we are at a good point, and I see less and less, to be honest, but that is, I am not aware of, or maybe I missed it, but that where a slide called NIFTP by me or by somebody else was passed on to other people to say, is this a NIFTP? No. And thank God, I have not seen a case that was called NIFTP that has metastasized. So I think we are in a pretty good place. We're going in the right direction. I hope I answered your question, but at this point, I can only tell you what our personal experience has been.
And I think that's kind of like the key thing that, you were on the committee that developed these criteria. And so the way you're describing or the way that you're calling NIFP is probably very consistent with those kind of very low malignant potential or metastasis. But I think the concern is also, in the community for someone who isn't on these guideline committees, who is reading about these, like, is their NIFP this actually truly NIFP? And if not, now that it's not considered a diagnosis, like, do they get lost of follow-up? Like, how are we managing these patients and how do we properly address that? I think that remains like a huge concern. And so a question I had actually is, in terms of the naming, like, was there a consideration for having not cancer per se, but something like, so I'm thinking in breast cancer, there's ductal carcinoma in situ. It's a very low malignant potential, but because it has in situ in the name, likely it's still followed in terms of long-term data. Was there consideration for having something that wasn't quite cancer, but had that name just so it'd be followed for long-term outcome data?
So, so if you really think about thyroid tumors, the word in situ is you have to take it with a grain of salt, right? The only lesion that I personally think is in situ is in a C-cell lesion, right? You have that C-cell hyperplasia, then you have a C-cell, then you have a microcarcinoma, and then you have a, outright carcinoma. So I think that is not easily swallowable. And we had a major discussions about, I actually personally fought, being from a cytology point of view, to really use papillary-like nuclear features, because to me that was very important, because on cytology, they are still showing those nuclei. So to really have, otherwise everything that cytology will do in that group will come out as benign, So even there was a thing that to just call it follicular neoplasm or a form of follicular adenoma. So we went through a lot, but the concept of in situ in the thyroid is pretty muddy. There is, we know about the C-cell, but for a follicular, we don't know how these tumors, we have an idea, good idea how it starts, but to say, this patch of a follicular clonal proliferation is going to do that. And then you have on the top, a lot of bad and fairly good, but not so good data on Hashimoto's thyroiditis, which is also very common in North America, which can have these areas which can really mimic papillary carcinoma. So, and there are some papers that those are in situ carcinomas, So I don't think it's really that clear cut in that. So we really did not want to add something which is going to really mess up stuff, And actually, if we have added this, I bet you have actually ended up seeing a very high incidence of NIFTP, because then why should a pathologist sit there and say, call this a follicular adenoma or a benign nodule? They're going to, if you're going to looking for that one groove or a clue, you're going to find it, right? So, so I think that's what was, I think it's the pace. And what you pointed out, the pathology practice is not limited to large reference centers or somebody who's actively involved. There's a lot of community practice also, and it's everyday practice of pathology. So when you come up with something, and I am very proud of this name. I was just part of I was a very, very small part of this giant group of experts that to really have a name which explains all the pathologic diagnostic features to look at. So which is really does not happen in pathology that often. So I think it may in the future, but I think I'll be retired by then. So.
Thank you for that.
Everything is frozen. Oh, no.
I'm sorry. Are you able to hear me, Zubair?
Yes. Yeah, I can hear. Maybe you can hear us, right?
Yes, I can.
Okay. I'm sorry. I lost my connection here. So I'm trying to reconcile the nearly six-fold difference between reporting of NIFTP in California and in just up the road in Seattle. And that's as I was looking at the list in reviewing your article, I was trying to come up with some common theme here. And I guess maybe the best explanation here perhaps is this inherent bias on the part of pathologists to not, I suspect it's easier not to call something NIFTP. Is that the takeaway message here, Zubair? Or Debbie, do you have some other explanation for why there is this discrepancy?
You know, the way that we interpret that data with so much heterogeneity, as you point out, kind of dependent on what state it is much more that there, you know, how pathologists call NIFP and who's willing to call it, I think it's pretty variable. And so I think, you know, we thought about looking more specifically at like which hospitals, but we just don't have that data access. Like it doesn't provide that granular data from SEER. But I would say the takeaway is very much so that it is variably used and it's not consistent. And it's and the nice thing about SEER is that it does take into account academic and community practices. You know, it's pretty representative of the general population, and including rural and more city areas. And so I would say the takeaway that we had was that it's just variably used. But I don't know, Zubair, you had more input on that.
No, I mean, it's a good question, but it has to be looked at. The data has to be very granular. And you know, when you read some of these papers that are being published, you really have to take all those things in account. You know, how many of them already had a carcinoma, the other carcinoma, and then NIFTP was a secondary diagnosis for another lesion. Was it a part of a completion thyroidectomy specimen, and the patient had some angioinvasive tumor, and now you have this other nodule? So I think it, but I without really looking at the data, I cannot tell you. And I think it does boil down to who's making those diagnoses, because it just cannot be the patient population heterogeneity, you know, from that point of view, because you suddenly do not have an increase in patients with NIFP. So I will say that sometimes, you know, the NIFTP diagnosis, when I make that diagnosis, I do look at the FNA diagnosis and the molecular profile, which kind of really also helps me guide at least what I'm dealing with is a low risk tumor. And if I see the nuclear features, then I really make sure that it does not have invasion, and then I will call it NIFTP. So that may also play in part in there, but I think I am really do not have much to add, because I think that type of data is not provided in those papers. But I do know that among countries it's very different. But I think maybe we'll get back to this topic in 5 years and then see how does it come down to.
So we have a question from our audience relating to the impact of an HRAS mutation on NIFTP, I guess biology. Does that impact you at all?
Now, to be honest, we had like 5 or 6 cases of HRAS in the NIFTP, and it did not. I will tell you that there were 2 of them were oncocytic NIFTPs, but no, I personally have not. If I see a KRAS mutation, then I am a little bit more, because to me that is more in the oncocytic type carcinomas. And as we know, oncocytic cells can sometimes mimic nuclear features of PTC, so I will really a little bit. But to be honest, that I looked at 5 or 6 cases again, and those were all still NIFTP. So no, but 2 of them were oncocytic. So I personally have a very limited to tell you, and I think is also listed what is in the literature.
So I'm coming at this from a surgeon's mentality, which you may consider to be somewhat simplistic, but my thought in this is that the diagnosis of NIFTP is based on what you're seeing under the microscope. But now you're telling me that you're bringing cytology, you're bringing in molecular information here, and so now I'm really confused. I
didn't mean to confuse. The thing is, so you know, we always talk about multidisciplinary approach to thyroid tumors, right? So for me, what I was mentioning that the NIFTP is a part of those low risk neoplasms. So the molecular profile lacking a BRAF V600E mutation a molecular profile with a low allelic frequency or showing other mutations or fusions which are low risk, and there's not complex molecular profile, most likely what you're dealing with, and if the radiology also matches that this is a nodule which is non-invasive, then you know that you're going to be dealing with a tumor which is confined to the thyroid. And on surgical pathology, what you're matching it, most of these will be tumors that are of low risk, unless there are some angioinvasive tumors or stuff like, which is another paradigm. So for me, this really points out to, and this is how our practice has been. We have seen a rise in lobectomies based upon the radiology and what the site, most of these on cytology are follicular neoplasms or suspicious for papillary carcinomas. They're not outright called as consistent with papillary carcinomas, and that's what the literature shows also, or actually more the Bethesda 3s. Then you know that the outcome of majority of these with this radiology, cytology, and molecular profile, you're going to be dealing with a low-risk neoplasm. So, and NIFTP is a part of one of those low-risk tumors. So I think that's where I was coming from, Mark. But I think preoperative assessment does point out that this is going to be a low risk, and if the cytology is also matching with it, then the patient person. I mean, I don't see patients, and it's not like I'm doing surgery, but you know, it does point out to a surgeon that you most likely are going to be dealing with a low risk tumor. I mean, Debbie can more comment on that because she refers patients for surgery and discusses this. So I mean, so what do you think about that, Debbie? What is your thought process about that?
Yeah, we actually at Michigan, we don't get a lot of NIFP cases. And so I think it, and we've talked to our pathologists a bit, and I think it comes down to kind of what you've been highlighting. You know, there's just so much variation in terms of who is who is diagnosing this as NIFP versus is this an adenoma versus is this like some version of like a differentiated thyroid cancer. And so it's hard to say. I think a lot of this main thing just really highlights to me that there's so much variability in how this NIFP diagnosis is coming to be made. And ultimately, I think the lack of long-term outcome data is the part that is concerning, because you know, if we consider a true NIFP to be one that meets all those criteria, which is how you're describing it, like, yes, that's much less concerning, but when it doesn't meet that criteria, like, what do we do with those patients? Like, are they still being followed in their institutions? Are they being lost to follow-up? And how do we reconcile that? I think that's the question that I've been trying to figure out. And I think ultimately it comes down to like more policy changes or more higher up, not at the institutional level, because regardless of how these diagnoses are being made, whether it's retrospective, whether it's prospective, you know, it's made. And so if patients believe this is benign and it's not truly an accurate diagnosis, what is the harm down the line? I think that's my takeaway point.
So am I to conclude that Ann Arbor has relocated to California with that low incidence of NIFTP? Let me just ask you, are you aware of any follow-on studies to the Parenti and the Cho series where they did a deeper dive on those bad actors that did show malignant behavior to see if they would have been classified based on the stricter criteria? Was anything, are you aware of any follow-up to that, or it is what it is?
I searched the database last night just to see if there was anything new on it, and I didn't see anything. I don't know if you have, Zubair?
No.
Yeah.
I mean, I think I know this webinar is this journal club is on NIFTP, but I mean, if you really think about the tumors, which are even if they're invasive, they're encapsulated, the invasion in the capsule, and maybe even a little bit transcapsular, no angio invasion, regardless of the nuclear features of PTC or not. I think you're dealing with tumors that are very low risk of recurrence, and basically those, you know, in a sense, very low malignant. So I mean, if we focus on that, I think, and I bet that within next 10 years or next 5-6 years, you're going to see that. And I will look for that, even if I'm retired, because to me, that is very, very important. And I think that's where it has to boil down to once we agree. So, I think this was a good discussion to really bring that forward. But I think, we have to realize that not all things are cancer, outright cancer, malignant, and it's everything that happens is on a spectrum, and the molecular profiles show us that. So, if you have it, why not, look at it as a guide? How are you going to manage them?
Terrific. I've got another 30 questions, but unfortunately, we're up against the 9 o'clock hour. In fact, we've gone over. So this is certainly something that we will return to at a later date. But I want to thank both of you for really outstanding presentations, discussions, and hope you'll come back to join us again. I do want to put one final plug in for the World Congress coming up in London in mid-June. Hope that folks will schedule their trips to head over across the sea. In any event, thank you all and hope to see you again next week.